Sir, these are images CT abdomen performed in plain, arterial, photovenous, and late phase images, in which I would see that there is distorted morphology of the left kidney, which is showing uh, blush of contrast, which is progressing on photovenous and the late phase images. I did not see this hyperdensity in this region on the plain phase or the unenhanced examination. Appearances suggestive of active bleed. In addition to this, I see that the morphology of the visualized superior pole of right kidney appears to be normal. Unremarkable bowel loops are seen. And so this is all from my side.
All right, so wonderful. Can you hear me now?
Yes, sir, I can.
Yeah. So I'll just add on a couple of things which might help you. I know these are not the complete films. These are just the representative images that we have collected. So you of course have to correlate with the history of the patient. This patient presented with constipation and bleeding, rectal bleeding. So this is not exactly the kidney that we are looking at. But that's another issue. You can always scroll through the films. This is basically a colonic lesion, and you can see there is lobulation. You can identify some of the calcifications within this area, and then you can see, like you said, this is enhancing arterial phase, then venous phase, and the contrast is pulling in. So, so what is your primary diagnosis?
Sir, this appears to be active bleed, and if this is a colonic lesion, I would raise possibility of angiodysplasia.
So it's a bit difficult film. I know I can understand at your level, of course. So this is primary. I just wanted to show you that some of the films are very difficult in a sense that sometimes you're not really tuned and you're not really used to look at these lesions at some other areas. So perhaps if I'll show you this lesion somewhere in the subcutaneous soft tissues, you'll quickly pick it up. But there are a couple of films within in the exams which are very sort of surprising for everybody. So just to get your attention, this is colonic hemangioma, and this patient got resected. And he had a surgery, and then on biopsy, it also coincided with our findings of hemangioma. So this is hemangioma. So you need to understand that the hemangiomas can act like hepatic hemangiomas anywhere in the body. So they can, pull the contrast, progressively on the venous and delayed phase. So you will see this pattern of hemangiomas if they're elsewhere in the body, whether in the subcutaneous soft tissues, intramuscular lesions. So they can still, present like a hepatic hemangioma. So this was hemangioma, and these were phleboliths within this lesion.
This is an X-ray skull frontal projection. There is a soft tissue swelling on left side of the face near adjacent to mandible. Showing no calcification. I cannot identify any calcification in it or any fluid level or any like this is not an abscess. I think this is a soft tissue swelling with some fat recencies I can appreciate. It can be a lipoma.
Okay.
Hello, sir. Can you hear me?
Yeah, I can hear you. So good description so far. This is the same patient with MRI. Can you describe the lesion here?
These are the multiple MRI images. T1 images, majority, and some are and one of them is post contrast. This is showing a lesion, which is adjacent to the left mandible, which is showing post contrast enhancement. I think this is also a hemangioma. If this is
Yes.
the same patient.
Yes, you're right. So this is hemangioma. I just wanted to show you, just connect the first case with the second case. The only thing that you missed is, I hope you can see it, that there are phlebolytics within this lesion as well. So
Yes,
these
sir,
are,
but I cannot just appreciate. Yeah.
so can you see
Yes,
that?
sir. Yes,
These are
sir. Yeah.
phlebolytics within this area. So a couple of things that you need to remember, that lipomas usually have different lucencies,
Hmm.
and you must identify when you're sitting in a cardiovascular station. You must identify if there is a swelling. Always look at phlebolytics. This is really important. So these are post contrast dynamic images, and these are T1 and T2 images, and these are dynamic post contrast images. So here you can see again, the contrast is pooling in. This is the arterial phase, just the arteries are visible. Now you can see the veins, and then the contrast has started pooling within this lesion. So you can see that. So this is the late phase. The whole contrast is, kind of pooling in. On T2, you can see those low T2 signal areas, and some of them are bright. So these are those phlebolytics that we were looking at. So this is again the hemangioma that I was talking about. So they sometimes follow the pattern of hepatic hemangiomas. They tend to progressively pool the contrast within them. Kid, and he had trauma. So this is your first film.
Okay, this is provided MR axial images, uh, T2 image, uh, sh- showing there is an hypointense area, hypointense signal involving the right temporal region. Mm, uh, mm, uh, uh, rest of the visualized uh, brain parenchyma appear unremarkable. Uh, Left orbit appear unremarkable. Uh, so
So these are the
the
next film, same patient.
okay, MR uh, coronal T2, T1, T2 sagittal, and gradient images provided showing mm, considering trauma. Mm, there is an rounded hypointense signal involving the left orbit,
Right.
which is low on T2 and low on T1 and on uh,
Yes, you're there.
mm, low T2, low on T1 and mm,
Which region is this? Where do you see this? Is it in the left orbit? Is it intraconal, extraconal? Can you?
mm, it's near the superior rectus muscle.
All right.
Uh,
And what about incidental images? Can you appreciate those signal areas?
yes, on sagittal images, there is a linear hypointense signal which is extending to the inferior wall of the orbit
Exactly.
is noted.
All right. So wonderful. Now we'll go back to the previous film. Now can you appreciate something there?
Uh, yes, there is a hypointense lesion in at the expected location of the cavernous sinus.
All right.
That is the same lesion on the hypointense lesion. So, on the basis of these finding, uh, so, like findings are likely suggestive of uh, uh, cu- uh, keratocaverous fistula.
Yeah, cardiac fistula. Yes, you're right. So, do
Yeah.
you want to confirm it on any other modality?
Uh, uh, the CT scan or
Yeah, you can always go for CT
mm,
angiography, but I think best is if you directly go for conventional because you have to
yeah.
differentiate between direct and indirect
Uh,
varieties. Yes.
okay.
So, can you just quickly describe this film as well?
It's a angiogram image of of the left cavernous sinus, which is showing uh, dilated superior ophthalmic vein,
Yes.
and there is multiple collaterals uh, uh, are noted with a normal communication between the carotid portion of cavernous portion of carotid
Yes.
and the superior ophthalmic vein.
Yes. So basically, the tip is here, and they're doing the carotid angiogram, and you can see the blush here, and this is that dilated superior ophthalmic vein, which you usually don't see. So this is extending from the cavernous sinus, and that's exactly what happened. This is carotid cavernous fistula post-traumatic in a young child. You can appreciate all those tortuous tubular
Yes.
areas here, and then this is the superior ophthalmic vein.
Yes.
Again, you can see that this is, high flow malformation. So this is CCF.
Okay.
So let me just quickly go through a couple of things and couple of tips for our candidates. So whenever you look at the malformations, you're dealing with them, always look at 2 or 3 points. And I think that's going to be very helpful for you guys. The first thing is that whenever you see a mass, uh, so there are two kind of major, I would say, malformations. One are more of a mass-like, a tumor-like, and some of them are more tortuous, tubular sort of malformations. Also, you have to see whether they are slow flow or they are high flow malformations. So the key is that whenever you look at the mass-like area and there are a couple of voids inside, phlebolytes, always think of hemangioma. Or they can be other tumors, such as soft tissue tumors, such as rhabdos, some of the muscular tumors, or maybe some other soft tissue tumors. So always think of hemangioma when it's more like a mass. So whenever you see more of an infiltrative lesion, and still you have high T2, and you see that it's infiltrating within the muscles and the surroundings, these are low flow venous malformations. So low flow is always bright on T2, whereas when we look at the high flow malformations such as AVM and AV fistulas, these are usually low on T2 and mostly on T1 as well. So that is how you differentiate between low flow and high flow malformations. You need to describe it in your descriptors. And then ancillary findings are, yes, with venous malformations, sometimes with hemangiomas, you may look at the phlebolytes. And for lymphatic malformations, you may sometimes find large cystic areas with the fluid levels. So these sometimes coexist together. So there are some of them which are venolymphatic. So this is something that you need to remember. Mass-like is hemangioma. Low flow malformation is always bright on T2. More infiltrative, think of venous or lymphatic. And if it is giving you flow voids, then it's high flow malformation. Just like our CCF, it is very low on T2.
Sir, now this is the X-ray frontal projection of the skeletally mature patient, which is provided to me, in which I can see that there is well-rounded, well-bounded opacity seen in the region of left hemithorax, likely in the region of pulmonary artery, along the pulmonary arch, which is not well seen. However, sir, some uh, subsentinel nodules, these are also evident in bilateral lung fields. Uh, this opacity is well rounded and appears obtuse angle with the lung parenchyma. So it is extra pulmonary, sir.
So, what is your diagnosis or perhaps differential diagnosis on this?
Sir, as it is having, I will ask the patient about its fever, cough, and night sweats, whether it is some aneurysm uh, lying in the region of pulmonary artery Rasmussen, if he has history of TB. But to me, the lungs appears clear as such, except other than small tiny nodules, evident.
Which are mostly vascular. These are just end-on vessels. I think. Yeah.
Okay, fine, sir.
So same
Um,
patient.
So these are the multiple section axial slices of the CT chest mediastinal window, in which I can see that the pulmonary artery or the pulmonary artery is massively dilated. It is not in ratio of uh, descending aorta, and the inferior branch and the branch of the pulmonary artery inferior on the left side is dilated, sir. To me, sir, appears.
So what is your diagnosis then?
Sir, it is aneurysmal dilatation, sir.
Of?
Pulmonary artery, sir.
All right. So this is just the focal aneurysm, probably side ectasia of pulmonary trunk. I give you that. This is primarily left pulmonary artery, and you can
Yes, sir.
see that right pulmonary artery is not that much dilated. So basically, the area of concern is the left pulmonary artery. So this is the
Yes,
aneurysm
sir.
of left pulmonary artery. Yeah. So
Yes,
you're
sir.
absolutely right.
I've been provided with a CT and pulmonary angiogram, reformatted coronal image, in which I can appreciate that there is uh, a serpentinous vessel in the right lower region, right lower lung, and
So this
the
is a
rest
bit
of the.
confusing. I can understand.
Can
This
I
is
see the next image, the adjacent images?
I just wanted to, so the good thing is that you picked it up, that this is reformatted images, and that's what I wanted to hear. It's not very easy. Sometimes you get confused what this exact, what that this is. So this is basically the MIP image. So this is the real, source images of this patient.
Okay. Uh, CT chest axial images, in which I can appreciate that the pulmonary artery is pulmonary trunk, as well as the right and the left branches are dilated as compared to the ascending and descending aorta, and there is a uh, focal narrowing of the right pulmonary artery uh, just after its origin.
This could be due to volume averaging.
Okay.
What about next couple of images?
Uh, right atrium is enlarged,
Right.
and there is some bowing of the interventricular septum towards the left ventricle in the second image. So
Mm-hmm.
it can be a strain, a right ventricular strain with
Mm-hmm.
pulmonary hypertension,
Yes, wonderful.
and the IVC appears to be slightly, I don't know, it appears dilated. Handy.
So, what are your differentials in this? Because it's a pretty much straight film. So, if anyone asks you what is the differential, so can you jot down a couple of differentials
So
here?
right ventricular hypertension can be because of some chest wall issue like COPD. I mean chest problem, pulmonary issue like COPD may be
Issues
caused.
can be can
Hi,
lead to
well, जी sir.
what else? what does. So you can also think of some of these subtle defects. Yes. So initially they can, just let's suppose if there's ASD, so left will go towards right, and that will dilate the entire right system, and
Yes, sir.
eventually leads to sometimes Eisenmenger complex and leads to reversal. So you also need to think about those things. Then there are rare things such as ARVCs. That's arrhythmogenic right ventricular cardiomyopathy. That's very rare and nobody is going to show you, but you should just keep that in mind as well. Sometimes the right ventricle is dyskinetic. It's sort of not well formed. It doesn't contract that well. So these are a couple of differentials that you need to keep in mind.
So I have been provided with the multiple exit slices of a contrast enhanced CT brain of a 65-year-old female patient who presented to us with a bilateral vision loss. Here I can appreciate that there is mucosal thickening with local multibilateral visualized ethmoid sinuses. Coming towards the orbit, I can see that there is no significant abnormality related to multibilateral visualized venous. Um, next, um,
Can
I
you
can
speak into
appreciate
your
that.
mic, please? Yeah.
So is it clear now?
Better?
Is it clear now?
Yeah, I can hear you. Please go on.
Hello?
Yeah, I can hear you. Please go on.
So, there is fantastic classification is mentioned involving the right coronary sinus.
What's your diagnosis then? So your diagnosis, please.
Sorry, we can't hear you.
Can we give this film to somebody else, or should I just explain it?
Okay, 68. 68.
Assalamualaikum.
I'm provided with multiple axial um, CT scan images of this as well, with soft and bone marrow as well. There appears uh, irregular enhancement of the medial aspect of bilateral orbit, extending towards the orbital apex into the bilateral cavernous sinuses, in the region of bilateral cavernous sinuses, more so on the right. Anteriorly, this enhancement is extending towards the prefrontal soft tissues as well. On the soft window, I can see that there is associated bony erosion in the frontal sinuses with some enhancing soft tissue mucosification of the ethmoid sinuses as well. Uh, and on the last image, I can appreciate that there is expansion of the frontal bone with destruction of the outer table and widening of the diploid space anteriorly. Um, so the
Your
differential
diagnosis, please. Yeah.
uh, sir, um,
You
diagnosis.
described it nicely. Just sum it up.
Um, so there's some process that is eroding the bone. So um, some um, can it be fungal infection?
Yes. Why not? Because the epicenter is the sinus. Yeah.
Then eroding the sinus. So it is then sinusitis. It finds sinusitis along with intraorbital extension and cavernous sinus thrombosis as well.
Yes. Exactly. So this is cavernous left cavernous sinus thrombosis. which is this is a fungal infection which is everywhere within the orbits. It's breaking up all the bones, causing osteomyelitis. So this is extending into the cavernous sinus. This is not enhancing left cavernous sinus. Here you can see the artery and the sinus itself. Here there's another finding here that you can't really see the artery as well. So
Yes, sir.
this patient, these are the initial images. So this is I have a couple of serial studies of this patient. This is an old patient of mine. So here you can see the artery was there. Both sides they were present. This is the arterial phase, and then in this case, it kind of the artery disappeared. You can see the ICA, cavernous ICA as well, but on the left side it's gone. So the cavernous sinus thrombosis in chronic stages, you should remember, leads to stenosis of the coronary the cerebral arteries as well. So this is exactly what it's doing. So it's a chronic case leading to infarct here. Yeah, can you see that? So it's
Yes, sir.
bright, correspondingly bright on flare. So this is a case of cavernous sinus thrombosis secondary to fungal infection.
Thank you, sir.
Okay, I'm provided with the coronal images of the angio at the level of the lower abdomen and the pelvis, and I'm able to appreciate that there appears to be cut of the contrast at the level of the just above the bifurcation of the aorta, and there appears to be an intraluminal filling defect in it, which is extending into the iliac vessels on the reconstructed angiography. The vessels in the low iliac vessels appears to be uh, show fill up of the contrast from the collaterals. I think it's from inferior epigastric. So this could be an intraluminal filling defect resulting in the cut of the blood supply.
Yeah. So what are you going to suggest this patient?
So there might be multiple causes in it. It could be some hypercoagulable state, some
Okay.
like it could be a spectrum of some sepsis,
Okay.
or it could be like a condition or resulting in dehydration. It's a young patient, so these are the first conditions I will work upon to look out for the cause. And obviously, I would refer the patient for immediate thrombolectomy.
So of course you need to work up this patient, same patient. So I know these are difficult cases for you because this is cardiac MRI, but I just wanted you to get a touch of cardiac MRI in this session as well, because
Okay.
in days I think probably you'll have a couple of questions from cardiac MRI as well.
Okay, there appears to be filling defect in the left ventricle, which shows no connection to the walls of the heart, and it is appears hypo intense on the sequence. So, so could it be a thrombus?
Yes, perfect. So this is a thrombus, and I'm not going to go into a detail. Just wanted to show you that how cardiac images look like. So this is basically thrombus. These are white blood images, and here you can see that thrombus. It's right in the middle. It's not. It doesn't have any stalk. It doesn't. It's not like arising from any wall. So it's freely mobile. So that goes in favor of thrombus. Again, we perform early gadolinium images, and where you can see it's not taking up the contrast. Rest of the gadolinium is inside the myocardium.
I'm provided with multiple Excel MRI slices of adult patient with T1 weighted images and T2 clear images, T1 weighted images and T2 weighted images, and the contrast study and angio. So I can see some abdominal intensity lesions which are scattered bilaterally in the white matter. Uh, they are hypo on They are present in the left right frontal lobe as well as in the bilateral thalami. Uh, they are hypo with internal hyperintense area in the clear images and which are and also at the same intensity noted at T1 weighted images. On T2 weighted images, they are hyperintense mainly. In contrast study, they are showing no contrast or minimal contrast.
So which one do you think is the most contrast image? 1, 2, 3, 4, 5, 6. Which one?
Fourth.
Fourth one. This is basically SWI image, also called SWAN in GE.
SWI.
So this is SWI. Yeah.
Okay.
Now what's your interpretation?
Filling the single drop is noted.
So that signifies what?
Sorry, sir?
So that signifies what? If it's low on SWAN.
So it's a bleed or calcification.
Yes. So when there's a bleed, you have your TOF images as well. So these are, your time of flight images for your MRA. Can you appreciate something? Sorry, forget about this one. Can you appreciate anything here?
There is a contrast study. There is um, asymmetry is noted at the ambient cistern, quadrigeminal cistern. No contrast is seen on the right side, and there is no any dilatation of the vessels seen.
The same patient with CT angiogram.
I can't appreciate.
Alright, it's okay. So these are just representative images. So of course these are sometimes difficult. I just want you to get a grasp of some of the spectrum of vascular imaging. So here you can see there is no cavernous as well as supraclinoid ICA. This one is also kind of diseased. You can see a lot of collaterals around. This one is also beaded. So this is the case of moyamoya. Moyamoya disease. Yes. So whenever the cavernous and supraclinoids are gone, now when we go back, you can't really see any internal carotid artery here. So here you can compare the posterior circulation is relatively better, but the anterior circulation is gone. These are all collaterals here. So they tend to bleed, they tend to rupture and leads to intraparenchymal hematomas. So this is a disease. So what's the difference between disease and syndrome?
Multiple diseases, the syndrome in this disease is single pathology.
Yeah, so if it's idiopathic, non-inflammatory, progressive, vascular-occlusive disease, it's moyamoya disease. If it's with some kind of other background pathology, then it's syndrome. All right.
I am provided with the coronal reformated images of the CT angiography showing the great vessel of the heart with its branches and 3D reformated image. And I can well appreciate that the catheter is placed in the arch of the aorta. And there is at the level of the brachiocephalic trunk, there is a dilatation of the right subclavian artery with the few calcifications noted in the coronal reformated image, while the left subclavian artery appears to be normal in caliber. So there is asymmetry in the caliber between the right and left subclavian arteries.
Okay, your diagnosis, please.
Okay. Sir, can it be subclavian Steele syndrome or?
Sorry, we just have to, somebody's, telling me that we have very little time left. So this is basically a diseased artery itself, and this is the stent that you're looking at.
Stent.
Yeah, so this is the stent within the left subclavian artery. This is diseased artery. This is somewhat the spared one, and this is the diseased left common carotid. And here you can see this is also diseased. This is brachiocephalic, and then the proximal common carotid, right one, is also diseased. This is post-synoptic aneurysmal dilatation. Yeah. And here you can see there's another stent within the right renal artery. So what is your diagnosis now?
Takayasu arthritis.
Exactly, great. So any differential that you have in mind?
Sir, other vasculitis?
Such as?
Sir, great vessel, giant cell arthritis, atherosclerosis. Sir, like the other diagnoses are involving the middle and small side vessel, like polyarthritis nodosa, Kawasaki disease.
So I think Takayasu is fair enough. So you also need to know, if you want, some good distinction numbers, you can always, go with the staging as well. So this is, I think, type 3 Takayasu. All right. So in which the arch is involved, its branches are involved, and the renal artery is also involved. The abdominal aorta is also involved. You can see this is not really a regular sort of aorta. All right.